Good afternoon. Thank you so much for joining us and welcome to the National Ovarian Cancer Coalition's Ask the Expert live series. Today's program is called Your Questions Answered, a special program where we address all of your questions that you guys have submitted over the course of the last few months about ovarian cancer. So today we're joined by two incredible experts, Dr. Buttin and Dr. Godbee from City of Hope. And they are here to provide answers and insights and guidance to help you better understand ovarian cancer. Whether you're a patient, a caregiver, or simply just want to learn more, we're glad that you're here. So, we're just going to jump in and get started. But first, I just want to take a moment to recognize and express our gratitude for our partners to fund this program, which is GSK, Merck, City of Hope, of course, and Genlux. We're so incredibly grateful for their support of this program. So, to get started, I just want to recognize and thank you so much, Dr. Buttin and Dr. Godbee, for being here this afternoon. Would you want to take just a brief moment and maybe introduce yourselves?
Yep, my name is Barb Buttin. I'm a GYN oncologist over here in Chicago. City of Hope, as you know, has multiple centers all over the country. So I am at the center in Chicago. I see lots and lots of unfortunate patients with ovarian cancer and treat the various, stages of the disease, all the way from very beginning stages, but primarily um, the more advanced stages, recurrent stages. We have lots of exciting developments in that realm and celebrate with patients every day how far we've come in the treatment of ovarian cancer. So I'm really happy to be here and thank you all for inviting me to answer questions tonight.
Thank you.
And I am Dr. Natalie Godbee, a duplicate of Dr. Button. I'm a GYN oncologist as well with City of Hope, just based in Atlanta. And so I too also treat ovarian cancers, all of the different stages, the various types as well. We manage the chemotherapy and the surgical aspect of it. We also have various clinical trials to offer. Ovarian cancer has changed over the past few years, which has made treatment exciting for us. And so we're happy to be here to discuss it with you guys and hopefully answer the questions that you guys have. Thank you for having
Wonderful. Oh, thank you. The pleasure is ours. Thank you so, so much. Yes, and for those who are viewing, feel free to put your questions as well in the chat as we go along. Like I said before, we do have a sort of list of questions that we've accumulated over the last few months. So, but feel free again to put your questions in, and if we can get to those at the end of the program, we'll be glad to do so. So, well, let's just go ahead and start with the first question that we have that was very, we quite a few on this topic, but regarding risk in ovarian cancer. But what puts someone at risk, for those who don't know, what puts someone at risk for ovarian cancer?
Yeah, there's several, environmental things that puts a woman at risk for ovarian cancer. First of all, I think it is important to point out that ovarian cancer, generally speaking, is a rare disease. It is not common in the way breast cancer is common, where you have over 200,000, over 200,000 cases diagnosed per year. This is a relatively rare disease, and so it is an excellent question for you guys to ask who gets it and why. It is related to hormones, as so many female, ailments are. It is related to hormonal imbalances. So some risk can come from hormone replacement therapy. Some risk can come from hormonal abnormalities, such as conditions like endometriosis, polycystic ovarian syndrome, conditions associated with infertility, the treatment of infertility. Um, and then some risk can come from inherited conditions. And I'll let Dr. Godbee continue with that.
Okay. So, yeah, we do know that some genetics can increase your risk for ovarian cancer. The thing about it is majority of these are spontaneous, but about 10 to 15% of them are related to a hereditary condition. The most common that people hear about is the BRCA mutation that puts them at risk for breast and ovarian. But over the years, we've learned of some other mutations that are putting patients at risk of ovarian cancer. Some of those are like BRIP1 mutations, ATMs, RAD51s. And so we're learning now how to deal with those and how those tumors behave as well. And then also older age puts you at risk. Of course, we usually find it in a postmenopausal female, but occasionally we will see it in younger females as well.
Yes. Seems like we hear more and more about younger patients every day. It seems to be great. I know it's, low, but we do seem to hear that quite a lot. Can I ask a follow-up question to that? On spontaneous, when you say spontaneous mutation, would you mind explaining what that means in case some out there don't understand what that means?
Mhm. So more of a spontaneous where we don't really know what's going on. We don't
Don't
know
know.
the cause of it.
Got it.
As opposed to genetics, we know that there's a gene that's
Got it.
developing there that is causing the cells to mutate rapidly, versus, not really knowing what's going on.
So inherited versus one that we know about versus a spontaneous gene mutation that we don't really know what causes
Mhm.
that or when. Okay, got it.
Mhm.
Thank you. Thank you. Okay. Second question related to risk is how does ovarian cancer differ from other gynecologic cancers that we hear about in terms of its causes, its risk factors, and maybe some of the symptoms? Would you mind kind of talking through that with us? Because, there's so many in the same area and they seem like they would all be related, but they're not quite. So would you mind speaking to that?
Yeah, I think it's always really important, I think, to point out the um, diagonal opposites that sit so close together, right? And that would be uterine or endometrial cancer, which is cancer of the uterine lining, and ovarian cancer. They're kind of like diagonal opposites. And what I mean by that is that endometrial cancer is relatively common. It's becoming more and more common. The incidence is going up,
Yeah.
whereas the incidence of ovarian cancer is actually slowly going down, which is a good thing. But the incidence of endometrial cancer is going up, which is not such a good thing. Um, and endometrial cancer, on the other hand, is relatively non-lethal, non-aggressive. We can detect it early. It has early symptoms. Generally, those symptoms are abnormal bleeding or postmenopausal bleeding. So something like that typically sticks out to a woman and brings someone to the doctor in some fashion. Whereas ovarian cancer has very, very subtle symptoms, symptoms we tend to ignore or push to the side, maybe just a little bit of bloating or slight changes in bowel habits, bladder pressure, early fullness after eating, something very subtle, as opposed to, oh, I'm 65 and all of a sudden I feel like I'm getting my periods back.
Mhm.
So opposites in that regards. Majority of endometrial cancer we can cure with surgery alone because we diagnose them early, because we have early symptoms. The majority of ovarian cancers are diagnosed at later stages. We have subtle symptoms, often not diagnosed at an early stage, often misdiagnosed,
Mm.
and therefore a lot more treatment is necessary by the time someone is diagnosed with ovarian cancer, and fewer overall patients are cured.
Mhm.
So there's the diagonal opposites there. But what the
Very,
two have in common, both of them are related to hormones. The majority, of
Very true.
course, not all, but the majority.
Mhm.
And then
hormone
there,
related. Yeah.
yeah, then there's cervical cancer. I'll let you talk about that. That's totally different.
Yeah. So I want to add before we go further is that there are different types of ovarian cancers. And what we're mainly speaking about today is the most common epithelial ovarian cancer that we see.
Sure.
That's usually a high grade and aggressive type cancer. There are other ones that are lower grades and
Yeah.
different cell types that tend to present differently. Those are even rarer than the typical ovarian cancers that we see. So we'll just kind of basically talk about the epithelial ovarian cancers.
Thank you.
But the cervical cancers that we treat as well as GYN oncologists, typically we can pick those up early as well, as long as a female is getting her pap smears done on a regular basis. And I know some of the misconceptions that I hear about pap smears is that it's going to check the ovaries, which it does not. The
Right.
pap smear only checks the cervix. And so we're able to pick up on cervical cancers earlier, as opposed to like what Dr. Buttin was saying, is that, sorry, I lost my screen here. I don't know if, can you
Uh-oh.
guys still hear me?
Yes, we can still hear you. Yes.
Okay, sorry.
Good to
Um,
go on our end.
but I'll just go without my video here.
Sure.
But the ovarians present much later.
Okay.
And so patients have those vague symptoms that we often attribute to just some GI upset.
Mm.
Oftentimes, unfortunately, if patients seek any workup for it, they, get pushed out, referred to GI for a workup as opposed to getting the appropriate imaging that's done. And that's when I tell a lot of patients to, be an advocate for yourself, because you know your body. And if you know that something is different, definitely, continue to say, hey, this isn't right. I need more done.
Yes, thank you for that. Thank you for saying that for sure. So it sounds like, just in a little summary of those points, the endometrial and cervical are both fairly well detected earlier, whereas with ovarian cancer, we know we still don't have a screening test to find it early or at all. Okay, so that's one of the big major differences there. I really appreciate you guys talking through some of those differences. I found that to be really interesting and helpful. If you don't mind, if I insert a question that we got from the audience regarded to this, um, and if you have anything to say on this, but we've gotten two questions on this so far, but wondering if there's any sort of screening in the works in research, or if you've heard anything that's coming down the pike. I know that this is a question that we get asked quite a lot.
There's been a lot of
There's
research,
been a lot.
done and ongoing about screening for ovarian cancer. It has been a very, very hot topic, as you can imagine, for, 2 decades now. Nothing has, come out as a perfect screening test. We have some combination tests that combine, some blood tests and then some imaging characteristics, ultrasound characteristics, that give you like a calculated risk score that the gynecologist can use when someone has an ovarian cyst or a cystic mass, to triage the patient based on that risk score as to whether or not that patient should maybe see a specialist, be triaged to see one of us, a cancer doctor, to have us look at that mass, because the risk for ovarian cancer is higher, but it is certainly not the equivalent of, a mammogram, a diagnostic mammogram that
Sure.
can really hone in and say that is a malignant looking mass. Even without a biopsy, I'm telling you, that will be a cancer. It is really still kind of in its infancy, but at least it gives some level of triaging that community practitioners can use, and in conjunction with radiologists, to give the patient a little more of an idea when they have an ovarian mass. Is this something dangerous? Is this something I need to have taken care of immediately? Do I need to see a specialist? Or can I have this watched?
Sure. Sure. Okay. Thank you. Thanks.
Okay.
Appreciate that. All right. And one of the final questions in this area regarding ovarian cancer and where it usually spreads to or metastasizes, where does ovarian cancer tend to spread compared to the others that we talked about, maybe endometrial and in cervical? Are they similar? Do they tend to spread to other places different from each other?
Yeah, it's a little different, and I like to try to explain it based on anatomy.
Mm,
If you look at
sure.
the endometrial lining, it has borders with the myometrium, which is that muscle wall of the uterus. And so oftentimes it's contained into the uterus. Um, some of the more aggressive types can spread outside of the uterus, but most of the endometrials will remain inside of the uterus.
Okay. Okay.
Similarly with the cervix, it's the cervix is that end tip of the uterus, and it usually grows from there and can kind of spread up or out a little bit. So it's usually a pelvic disease. Um, then with ovarians, if you think about the anatomy, the ovary is attached to the uterus with a little ligament, and then it has its blood supply. And then otherwise, it's just kind of floating in the pelvis there.
That's true. That's
And
true.
so when those cells start to turn over and spill, of course, it's going to go into the pelvis, into the abdomen, touch bowel, touch liver and spleen. And so oftentimes we see it throughout the abdomen and pelvis. Um, and it can usually present with what we call ascites or pelvic fluid. And occasionally it will go to the lungs as well.
Yeah. I don't know that I've ever really thought about that as far as the ovaries, like you said, with the anatomy, they're kind of out there in space in a
Mhm.
way. So they're
And everything's
closer
just
to
touching
everything's
it.
just kind of, yeah. Wow. Well, thank
That's
you
so
for
true.
explaining.
Yeah.
Yeah.
I think of it too as like the ovary has no borders, right? There's
It
no
has no borders, right?
margin around the ovary. It's just open to the entire abdominal cavity. There's
Unfortunately, yeah.
no chamber around it that would
Mhm.
contain
Contain
anything
it.
that comes out of it. Mhm.
Great point. Thank you for talking through that. That's great. Yeah. Okay, so we'll shift a little bit from our questions to a little bit about treatment and research. So, regarding platinum resistance, for those who have platinum resistant or platinum, sometimes I hear refractory ovarian cancer, what treatments are currently available for those who fit into those categories? Would you mind speaking to that?
So I presume people are asking those questions because they know exactly what that is.
Yes, that's
Platinum
true. They
resistant
know
is a
it.
very specific
Yeah.
term, but maybe just to remind everyone
Sure.
else on the call. So platinum resistant ovarian cancer, that would be ovarian cancer that's already been treated once with standard, surgery and chemotherapy that usually contains a platinum agent, right? Most people get carboplatin and then paclitaxel in their initial chemotherapy, plus or minus perhaps another agent. And the hope is always that with those drugs and surgery that people go into a remission.
Mhm.
And that remission lasts a long time. That's always the hope of that initial
Right.
treatment. But if that remission does not last a long time, and in this particular scenario, if it lasts less than 6 months, meaning the cancer comes back within 6 months of the end of that initial treatment with platinum-based chemotherapy, then we call that a platinum-resistant reoccurrence. So less than 6 months. Platinum refractory would be someone that comes back even sooner than that, maybe even during treatment or immediately following the end of treatment. So those are typically cancers that are very highly resistant to chemotherapy. And of course, that is a group that, we really need to devote a lot of research efforts to because they're resistant to our best treatments. So what do we have to offer them? So that we have better treatment options for that group. Um, Luckily, we actually have some new treatments, especially for that group of patients that have recently made a huge difference. A huge difference, right? We've always had, or at least for several years already, single agent chemotherapies. People might have heard the names doxorubicin, topotecan, weekly paclitaxel, things of that nature. that would have been given to a person with platinum-resistant ovarian cancer. Basically, just other types of chemotherapy, slightly different mechanisms in hopes of attacking the cancer in that fashion. Now, over the last year, we have been fortunate enough to have gotten approvals of brand new types of drugs
Mm.
in a class called antibody drug conjugates, or ADCs. So these are chemotherapies that are attached or wrapped up inside a particle with an antibody that still get injected into the bloodstream just like chemotherapy, but that can only attach to and get inside a cancer cell if the cancer cell has a particular receptor, kind of like a molecule on the surface that allows, through this attachment, a door on the cell to open and let the chemotherapy in. So this is a much more targeted delivery of the chemotherapy. It doesn't just go to all the cells, which causes all the side effects and all the damage to healthy tissues.
Yes.
This is now a very targeted delivery to cancer cells through a receptor that a lot of these cancer cells have. And we have 2 of these new drugs based on a receptor that are now approved for platinum-resistant ovarian cancer. Extremely exciting. And both of these are based on receptors that are pretty common in that group. One is called the folate receptor alpha, and one is called the HER2 receptor, both of which we test for now all the time. The minute someone comes back with a platinum-resistant recurrence, we immediately get a biopsy. If it hasn't been tested, we test for it. If the cancer expresses the receptor, we have a drug to deliver to you. And the response rate, sure enough, what got these drugs approved so quickly is that the response rates of chemotherapy that is now delivered through that mechanism is so much higher. Twice as high, more than twice as high than it is with any single agent regular chemotherapeutic that we've previously had for this disease.
So definitely made some good steps towards having other options.
Definitely. It's a start. You know,
Wonderful.
it's an exciting avenue,
Start.
and there will be more. There'll be more. There's
Yes.
a lot being developed as we speak.
Wonderful.
And of course, clinical trials, Dr. Godbee.
Yeah, I was just going to say that was a great explanation, Dr.
It
Buttin.
was a great explanation. Thank you.
Great explanation. So how these drugs work. Um, but yeah, anytime a patient has recurrent disease, well, even in the upfront setting, we always think about clinical trials because sometimes that will give them access to drugs that aren't necessarily FDA approved just yet, but they have some properties that show they may work in specific cancer types. And so we always encourage patients to enroll onto clinical trials if they qualify for them. And some of that is based off of the next generation sequencing or genomic testing that we do, which is Dr. Buttin spoke about testing for that folate and the HER2 receptor, but it also will test for other mutations that we could potentially target with other drugs as well. So clinical trials are always highly recommended if a patient qualifies for them.
Sure. Thank you. That's amazing. Yeah, thanks for bringing up clinical trials. Very, very important. Awesome. Well, that was a really great question and answer. Thank you. And you had mentioned earlier, I think it was Dr. Buttin maybe had mentioned earlier on the call that was it mortality rates for ovarian cancer have started to decline, or was that incidence rates? And why is that? Are you able to speak to that?
Yeah, it's actually both.
Both. Okay.
That are declining, and not rapidly by any means, but
Sure.
steadily. And that's exciting, right? This is a tough disease. We're just happy to see that it's not going up, it's going down. Mortality very, very slowly is going down and incidence is going down. So incidence, that probably has to do with a lot of lifestyle factors and probably with the fact that a lot more people are getting genetic testing, are getting high risk screening, and are getting risk reduction surgeries. Because that is the one thing that does work. We don't have great screening, but if you know that you're at risk for ovarian cancer and you have completed your childbearing, you can be proactive and get your tubes and ovaries removed.
Sure.
And certainly, I think more people are doing that today than probably
Mm.
10 or 15 years ago. And
So that
genetic
would have a big
testing
impact on that for
is
sure.
a lot more accessible now
Mm.
than it was, and people are more willing to do it. Insurance is more willing to cover it than
Mhm.
ever before. So I think that's in terms of incidence has had a big impact. But then mortality is also finally slowly but surely trending down because people are living longer, right? We have treatments that are prolonging life, that are helping people live even if we're not curing them quite yet. But at least, I would take it as a success too if we're allowing folks to live with their disease as long as they're having good quality of life.
Yes. Yes.
Good quality of life, the treatments that they're on, they're treating intermittently or they're treating continuously, are not robbing them of their abilities to function in society, live and, play and travel and work,
Thrive.
be with their
Thrive.
family,
Yeah.
thrive.
Yeah. Yes.
Exactly.
Yes.
Exactly. And
Yes.
that has definitely improved.
Those are great points. I don't think I would have thought about the ability to have the surgeries and the amount of those that are taking advantage of that. So that's yeah, that's a great explanation as well. You guys are wonderful.
I would add to that as far as the mortality rates going
Mhm.
down, more treatment options now. Usually, when I
Yeah.
give my lectures, I like to show a screen of where we've come from. So, like
Yeah.
back in the 70s, 80s, 90s,
Right.
we really only had like
Amazing.
4 drugs to treat patients with:
Amazing. Yeah.
carboplatinum, paclitaxel, doxorubicin, tolbutine. Like that was it. And, in the early 2000s, that's when we start rolling out the various targeted therapies from PARP inhibitors, VEGF inhibitors. And then now we got the ADCs that we were speaking about too, that's improving the overall survival and progression-free survival. So it's playing a huge role. And that's another reason why we recommend the clinical trials too, because once we can prove it, then we can get it FDA approved and allow patients more access to it
More
and to
benefit.
live longer.
Yep,
So,
absolutely. Absolutely. Well, if you can believe it or not, we're coming to the end of our time, but we've got three more questions here. We might have to do a part two. I don't know if you'd be up for that, but we might have to do a part two with all the other questions that are coming in. But thank you for answering that. That's really insightful. So, another question that we got asked quite a few times when we put this ask out there was about recurrence. I know that this is on, of course, everyone's mind at some point, but can you speak to how common recurrence is with ovarian cancer and what those options are, if we haven't already talked about that, for when ovarian cancer comes back and what that looks like?
yeah, the unfortunate reality is
Yeah.
that most of these do come back, and it's a matter of when does it come back.
When? Mhm.
We generally have an idea of how the tumors will behave, if they have any hereditary mutations, versus non-hereditary mutations. That's where that platinum sensitive, platinum resistant come in as well, where we look at the 6-month mark. That also tells us how the tumor is behaving.
Mm.
The longer a patient can go in their progression-free survival, the better the prognosis. Um, And then based on that is how we decide to treat, if we are platinum sensitive, then we're going to revisit some of the platinum agents and try to do multiple drugs at one time so that we can kind of hit the tumor from different angles. Um, and the platinum resistant route, we talked about that already. And then
That's right.
also the clinical trials, we talked about that
Correct.
as
Yep.
well.
Yep.
So, but yeah, the unfortunate reality is that majority of them do come back.
Okay. Yeah. I hate that. But
Yeah,
yes.
Yeah,
yeah.
yeah. That is still a big frontier that we have. But maybe one thing to add to that is that, we do have maintenance drugs.
Mhm,
Right. Maybe just to point that out, a lot of people know about those. So when you finish your primary treatment, right, you had surgery, you had chemotherapy, and you go into a remission, and the great majority of people really do, right? That's
Mm-hmm.
70% or so, will go into a clinical remission where we can no longer detect any cancer. Um, then the question is, how do we keep people there?
True.
Stay in a remission for as long as possible, right? And then we speak about maintenance treatments that prolong a remission. And that's where PARP inhibitors, right?
Mm-hmm.
These are oral drugs, pills
Mm-hmm.
that are utilized for that purpose. And they are definitely utilized for people who have an inherited mutation. But there is also a role for some people who do not have an inherited mutation, but where maybe the tumor has a mutation that it picked up on its own. I know Dr. Godbee
Mm-hmm.
spoke about that earlier. So there are some people that can really benefit from these drugs in that kind of case as well. So that adds another whole
True.
several,
Option.
decades of percents of people that benefit from these oral medications that way. There's still a bunch of people that benefit from maintenance with an IV medication called bevacizumab, right,
Oh,
which
that's
is a VEGF inhibitor, kind of just keeps the tumors from coming back. It's an infusion, but it's not like chemotherapy, something that people can have for at least a year or so, still with good quality of life and prolonging
mhm.
remissions under the right circumstances. So those are also, that is still another frontier we're working on as well, is what else can keep people in remission
Mm-hmm.
longer.
Longer. Mm-hmm. Right. How long can someone stay on a PARP inhibitor as maintenance after chemo or after a recurrence? That was a question that just came through.
Yeah, so they're indicated for either 2 or 3 years, but then we certainly, I'm sure you do too, have patients that have elected to go beyond and are still going.
Why
It's
not?
hard to pull them off when they see that it's working well. It's
Yep,
hard to come
Yeah,
off of them, which
still
I get it.
going.
I
I
get
get it.
it.
Yeah.
So 2 to 3 years is what the recommendation
That's
is. Is that
the
correct?
recommended, duration, but we certainly have some that are doing it much longer than that.
Is there a harm to staying on it longer? Do we know? We don't know probably, right?
Know that for sure.
Okay.
There are downsides, there are side effects, there
Side
is
effect, yeah.
small risk of developing, a secondary kind of cancer,
Mm-hmm.
but we do not know that that risk goes up with time. We do
Sure,
not know.
sure. Okay. All right. Wonderful. Okay, shifting here just a little bit to a question regarding having children after an ovarian cancer diagnosis. Um, the question that came in was, can I have children after an ovarian cancer diagnosis?
That is a great question, and I know I wish we could say, well, of course.
Right.
Uh,
And it really all depends on the type
the
of
type,
The
yeah.
ovarian
type of cancer,
cancer
ovarian cancer?
and what stage rather it was found in. Because at the time of diagnosis and you're undergoing surgery, the ultimate goal really is to get rid of all the disease that's there.
Yes.
And if it has spread already to those pelvic structures, that means both ovaries, the fallopian tubes, the uterus, and cervix, all of that has to come out. If we have a patient who has maybe one of the lower grades, confined to just one ovary, who's young enough to have a successful pregnancy, then yes, it's possible, and with the help of fertility specialists. But
Yes.
remember, most of these are found in postmenopausal women too.
True.
So
Very true. Yeah.
you have to look at the risk of if a patient is able to conceive and carry a pregnancy when you're thinking about sparing
Of
fertility.
course. Of course. Yeah. And I know that we have some programs coming up in the next month or two that are going to focus specifically on fertility. So that'll be kind of a part two of this. But
Mhm.
yeah. Okay.
Mhm.
But I think
And
you're
of
right. I
course,
think there are some types of ovarian cancer, that occur more in the younger age groups. The so-called low-grade serous
yeah.
carcinomas, or borderline ovarian cancers. Some of the germ cell ovarian cancers even arise in children, young, very, very young women. And in those cases, and that's not really the type of cancer we were primarily focusing on with our discussion, but in those
Sure.
cases, the answer would be absolutely yes. Yes.
Mhm.
For most of those, you can, and fertility can be preserved and is preserved at least for some time, and certainly for the lower stages. So it's not an all or nothing kind
Okay.
of.
Okay. And finally, and I just want to say here, if we haven't gotten to your specific question that came through the chat here, we will definitely answer those post program and put that up on social so that you'll have the answers for that. But kind of wrapping up the conversation here in terms of follow-up care, monitoring, survivorship, looking at what that looks like. What would you say from your perspectives that survivors should know about long-term follow-up care and monitoring? What does that look like?
I would say it's lifelong, to be honest with
Lifelong.
you. And
I
so,
agree.
like Dr. Buttin said, with the initial diagnosis, we try to get patients on maintenance therapy anyways. So they're going to be seen like every few months, if not monthly, depending on the type of maintenance therapy that they're on. Um, some of the oncologists will order labs, the tumor marker CA-125. I am a fan of CA-125. I do tend to follow it, but I also preface my
Yeah.
patients and let them know that that's not the one thing that we look for. So that's one thing that I particularly do in surveillance visits. And then, after we stop treatment, if we get to a point where we can stop treatment, it's usually still close follow-up after that, just to make sure that everything remains stable. I always tell patients again to just let us know if symptoms come back. So especially those symptoms that you had when you were initially diagnosed, a lot of patients will remember that and they'll say, I feel good, or nope, this feels just like it did a couple years ago when things were starting to brew. And so I tell patients to just let us know so that we can bring them in sooner. But the further they get out from treatment, we can start spacing those visits out a little bit. They get a little bit safer, in a safe zone for decreased risk of recurrence the further out they get. Once they get to a 5-year mark, then we do like annuals from there. But the conversations are still the same. What symptoms are you having? Please let me know if you're having any symptoms in between visits. Don't wait until your next visit. Call us so that we can start the workup process sooner.
Yep.
Okay.
I absolutely echo that. That's the most important thing, is to tell our survivors to just be in tune with their body. This is your post-treatment baseline, kind of get to know your new V2. This is how you are now that you've finished your treatment. If anything feels out of the ordinary, in between scheduled visits, let it go for a week or so. But if it doesn't get better, call
Mhm.
us.
Yeah.
Any symptom could be anything, right? You could have the flu, you could have food poisoning. Give it a week or so. But if it doesn't get better, give us a call. You know,
Mhm.
it should probably get checked out.
Yeah.
Um,
Yeah. If you don't mind me throwing in one more question that's related to that before we end, someone's asking, what are the appropriate scans if someone is having symptoms? And now, I guess that might, I'm not sure if they're talking pre-diagnosis or if they're talking recurrence. Um,
I think in most cases, a CT scan is a good starting point. A
okay.
CT scan, you know, for someone who has abdominal pain or symptoms, it's a very comprehensive test. You know, it really kind of gives a good overview of the abdominal organs, even bone structures. You know, it can usually give you a good idea of what's going on. And then if you know that something seems to be pointing to one particular area, you might follow that up with something more focal, like an MRI, perhaps of the pelvis or the upper abdomen, the liver, etc. But I think a CT scan would always be my first test of choice.
Okay.
Yeah, I
Okay.
think most oncologists would choose a CT first for diagnostic purposes. It gives a lot of information. I know a lot of people, the question is probably, can I get a PET scan? Because all of our patients ask for PET scans, but CTs really give you the information that you need.
That you're looking for. Yeah.
More diagnostic, more anatomical detail.
Yes.
A PET scan is really a cancer-specific scan, you know, most important when you already know there's a cancer. You want to know, is there something active? There's a strange finding on a CT scan. You want to do a PET scan on top of that to understand what the abnormality is. It's not a
Okay.
screening test, but a CT scan is so helpful.
Mhm.
You can get it from the chest all the way down to the pelvis.
Mhm.
Well, thank you. Thank you very much. Well, believe it or not, that time has gone by fast. We will definitely have to do some sort of part two. I think this has been so, so helpful. Some of the comments that are coming through are just, this has been really, really helpful and kind of answered a lot of the questions that were put out there. So thank you. And I know that we covered a broad range. So I really thank you for helping us out with those. But just thank you so much for sharing your time and expertise with us today. It's so helpful, provided a lot of clarity, I believe, for a lot of people looking for answers. So we appreciate it. We deeply appreciate your dedication to your patients and to these efforts that you put your time into. So we're definitely very thankful for you guys. So thank you for being here. And until next time, we will see you next time.
Thank you for
Wonderful.
having me. I
Thank
enjoyed
you for
it.
having me too. Take care,
Thank
everybody.
you.